Welcome. I'm Keith Sterling, interventional radiologist from Virginia, and I'm the Senior Medical Director for Vascular Therapies at Boston Scientific. So we have a great session for you today where we're going to be talking about the newest generation in intravascular lithotripsy with our SEISMIQ device. We're going to be talking about drug elution strategies. It's very case-based. And we have a fantastic faculty that I'd like to introduce to you now. We have Parag Patel from Medical College of Wisconsin, interventional radiologist. We have Sonia Noor, vascular surgeon from upstate New York. We have Rahul Patel, interventional radiologist from Mount Sinai in New York. And Nick Petruzzi, interventional radiologist from South Jersey. And they've got great cases. We want to make this interactive. We have, I think at your station, you have a QR code that you could scan. I have an iPad up here. We'll have questions. We'll try to weave in questions when everybody shows cases or after the cases, and we have time for a panel discussion at the end. So let me get started. This is our disclaimer for the session. And I'm going to turn it over because, you know, these things go really quickly. We have about 45 minutes to Parag.
All right. Thank you, Keith. It's great to be here and see everyone. Toronto's been a great meeting. And I think in the next 45 minutes or so, I think this is exciting to introduce a new technology within a space that I think if many of you are in the peripheral world, has seen a change in approach to treatment for really complex patients, particularly the calcified lesions. So this is an introduction to the SEISMIQ intravascular lithotripsy system and the mechanism of action. Many of you may have not seen this, so just a brief overview, and then I'll share a case example and hand it off to my colleagues. And I think we're going to hear a little bit more about kind of real hands-on experience that some of the operators, particularly Nick and Rahul, have shared. But SEISMIQ is a different mechanism of action. It's the same concept as IVL that you've come to know with the predicate device that's out, but there's more coming to bear. And this is really a unique mechanism that's fundamentally different, but also I think allows for a greater amount of energy. The mechanism is laser-based. There isn't a laser, there's no goggles, nothing like that, like you think of in typical laser devices, but that laser mechanism hits an energy source, a metallic target within the balloon, and creates what I like to that plasmic plume, right? And that plasmic plume really triggers the cavitation bubble. That's the mechanism that creates their cavitation bubble, which is unique to this device than what you've seen previously. That more powerful cavitation bubble is what fractures the calcium, and then their secondary cavitation bubbles are effects that can occur, or that do occur, that further fracture or expand that fracture. So that's the mechanism in which you see the IVL system work, and that's illustrated in the benchtop videos here, and you can kind of see that. So while it has a mechanism of action and basis for similar to what you've seen with other IVL therapies, how it delivers that and its ability and strength is fundamentally different. In addition to that, the actual overall system has some unique features that I think would be of benefit and worthwhile to those who've had prior experience to IVL. You can deliver the catheters. You can actually direct the therapy specific to where the lesion is. I think many of us have seen other lesions beyond just strict circumferential calcium, those eccentric popcorn-type calcifications where perhaps the emitter needs to be directed more focally to that area of lesion, problematic in many of our patients. Having a long segment of emitters is great for long lesions, but perhaps you need additional pulses focused on a selective area or a single area. So to be able to select which emitters you use, perhaps all of them, or towards the end of a case, problematic areas and focusing on one or two emitters to the area of the lesion that's most problematic or where that eccentric calcium is. And then some real-time feedback. Many of us have used IVL, have started to pay attention to a little bit of how does the lesion respond over time despite low pressure inflation changes in that. And so, quick overview, you'll see the emitter orientation is not uniform throughout the balloon. It slightly rotates, if you will, and you can see that depicted here in the different emitters, lettered A through D. And as you see that, you can then see the radiopacity and the marker of the different emitters. And so that emitter kind of spirals around the balloon, if you will, and you can then direct that to that eccentric calcium more appropriately, because as you do that, the stronger pulse, that cavitation bubble is going to be greater. That wave and subsequent secondary waves will be greater, more impactful when you position it as such. And likewise, you can then also, as I mentioned, select your emitters. So say you've got a lesion that spans the entirety of the balloon, as you see on the image on the right. You may choose to select only certain emitters that have that waste, persistent waste where the calcium is. And then finally, the console, which is a very different type of console unit than what you might have seen with prior IVL therapies, has a lot more information on it than you may typically expect. It goes beyond just counting down the number of pulses. It'll tell you, obviously, what cycle you're on and how many remaining pulses. It'll tell you which emitters, A through E, are on, which you can select on and off, and how many remaining pulses you have. It'll tell you the current atmospheres, and as that drops, as perhaps that vessel becomes more compliant and you get a reduction in pressure, that may give or signal perhaps a therapy gained. And so there's a lot more information overall that you get from the console itself. So with that introduction, I think a brief case to share. This is a 73-year-old with lifestyle-limiting claudication who had failed structured walking program. Has a significant ABI reduction of 0.63 and a toe pressure of 0. Arterial duplex imaging demonstrated multiple irregular calcified lesions, and you'll see that, I think, apparently on the angio pretty well. So initial angiogram images here. Hopefully you'll see that on the angiogram, and you obviously see the calcified lesions. It becomes apparent even in an unsubtracted view, probably very relevant. Runoff imaging. Yeah, you see the runoff imaging and you see the calcium. So this wasn't a challenge perhaps to cross, but it's really a challenging lesion, a very typical one where you see calcified lesions through the adductor canal. And so with that initial pre-prep, this is a 3x150 Sterling. You can see the angiographic images and typical eccentric, bulky calcification throughout the entirety of the lesion. SEISMIQ, a 6x60 balloon placed across the spanning of this lesion, so in overlapping fashion, and dilated. And you can see the emitters, very easy to see. You can see the inflation of that, and then sequentially done throughout the entirety of the lesion. You obviously want to assess for your treatment. Did I get some luminal gain before I do a definitive therapy? Again, I will emphasize this is a vessel compliance or modification, if you will, via a compliance mechanism, not typical end therapy or destination therapy. There we go. So you see a completion, you see maybe a recalcitrant stenosis there. You can come back with your SEISMIQ balloon, focus in a emitter at that location, and then follow that up with a more definitive therapy, in this case a Ranger, drug-coated balloon, trying not to stent in this location given its location, a 6x200 done. We always then follow that up with angiography and often with intravascular ultrasound. And so that was what was done here. What you'll see is the angiographic images, and you're seeing overall improvement in luminal gain compared to that index imaging, the intravascular ultrasound. Likewise, will show improvement in luminal gain, but also identifies, I think, a secondary lesion that we saw more or was seen more previously. And you'll see here a little more calcified narrowing with still significant luminal stenosis really at the top of that early IVUS run on the right. And so another identified lesion, but because you have the same balloon, and in this case the entirety of this case was done with a single SEISMIQ balloon, but because there were residual pulses left, you can see this more proximal calcified stenosis here in the more mid-proximal SFA. That was treated again with the same 6x60 balloon, and then followed up with a 7x40 Ranger, and here's the completion run right here. And so in this case, sort of in summary, multi-segment calcified, eccentric, bulky calcification treated with a single 6x60 SEISMIQ balloon, able to redirect emitters to a more recalcitrant stenosis at the index lesion, identified on the IVUS run a more proximal stenosis that was calcified, able to treat that with that same balloon because of residual pulses and cycles left, and then definitive therapy with a Ranger balloon proximally and distally with a good final result. Thank you.
Parag, great case. Thank you for sharing that. Before we go to Sonia, one question for you. You know, besides showing that you were only able to use one seismic balloon, I think that's a great advantage. How have you changed or evolved your practice in terms of use of IVUS to kind of dictate therapy in either using IVL or other therapies?
Yeah, so in general, IVL I feel has taken has allowed us to try to take on more complex lesions. In the past, it used to almost always be an atherectomy approach. It was a subintimal, try to cross through. If you got intraluminal, you're using higher pressure balloons, higher risk of distal embolization, higher risk of vessel rupture. So there was a hesitancy to say, how much further can I go? This is going to be really challenging. Now we have an option to try to change with that vessel, how that responds to a more definitive therapy. We're not doing high pressure inflations. We're doing a lower pressure inflation. We're able to change that vessel compliance to get that Ranger or a DCB or a drug-eluting stent, if that's ultimately what we're looking at to accomplish a more definitive therapy. And that wasn't the case 5 years ago, certainly.
Perfect. All right. Thank you, Parag.
Thank you.
All right, Sonia, you're up.
Thank you so much. Good afternoon. So my name is Sonia Noor. I'm a vascular surgeon. I practice in Buffalo, New York, and I practice both at an OBL site as well as the hospital site, and I think that has something really relevant for us to be able to do these kinds of cases, because there is that CMS code available now that we can certainly talk about. It's an adjunctive code. So 71-year-old female, I'll go straight into the case. You know, CLTI has a chronic non-healing wound, has ischemic rest pain. You do your usual vascular studies, and her ABI is 0.5. Her toe pressure is very low at 25. So clearly you know this is an ischemic problem in addition to her diabetes. So the duplex that you'll usually get in your vascular studies, I think, gives you a lot of information that sometimes we don't always pay attention to, but certainly the duplex showed distal SFA, popliteal lesion, some reduced flow and severe stenosis of the anterior tibial and tibioperoneal trunk. And quite frankly, I have a big OBL practice. This is good enough for me then to go in to the OBL, do a diagnostic angiogram, and see what I find. So you do your usual, you do your up and over sheath, right? You finish your diagnostic angio, and this is basically what it shows you. In your non-subtracted image, you actually see the calcium. So by that time, my staff is rolling their eyes, or if I'm with the residents, they're rolling their eyes about how hard of a case it's going to be. But in this case, you can see the SFA has multiple areas of occlusion, a lot of cauliflower-like lesions, very sluggish flow coming down to the tibials. Anterior tibial has disease, tibioperoneal has disease. And then the PT comes back as a very distal reconstitution, and the DP sluggishly makes its way down along with the peroneal artery. So it totally makes sense, multi-level disease in a diabetic who's here. So the next thing we have to do, obviously, is cross the lesion. As you can see, you get your up and over sheath over, you heparinize like you normally would do, and then you're taking a really close look at how you're going to navigate this lesion. Part of it is stenotic, part of it is occluded. You make your way across. And then I'm a big atherectomy user. So now in my head, I'd be thinking in my algorithm, okay, so I like rotoblator a lot. I use rotoblator atherectomy a lot in both sites, in the OBL as well as the hospital. And what's going through my mind is I got to be careful with the burr. I got to not embolize. Is it going to get stuck anywhere? Like, I'm really, really carefully thinking about how I'm going to do that. These kinds of lesions, I don't even think you can do a pre-IVUS, because I don't think the IVUS would track without a pre-dilatation. So in this case, pre-dilatation with a 3x60 in this area, 4x150 in that area, and now you have an idea of what you're going to do. So as Parag mentioned, this is really a plaque modification kind of tool, like atherectomy would do. It's a plaque modification, and you're already thinking you're probably going to have to treat this with something else, either a Ranger or a stent or an ELUVIA or something. So in this particular case, a total of 550 pulses were used, 6x60 balloon. And I just wanted to bring up this picture again. You're getting live feedback as you're doing this, that it's a 4 atmospheric pressures is where you started with. The balloon's now starting to drop. And you can see in the last picture, you can reorient it. So there's an I and an H. you can turn only those emitters on so that you can actually see what you're doing and that you're getting the result you want, so you know that's really when you're done. So just to reiterate those, that's the H and the I. And it saves you more time because we have shockwave now, right? So why are we talking about another lithotripsy catheter when there is one available? These are the advantages to that, is that you can really turn on and off the emitter that you want to work on, and you can get feedback, live feedback, as you're doing the case. So then the angiogram will show you, this is after a balloon angioplasty. Flow is not the greatest. There's some areas of dissection. The IVUS shows you there's still some disease. And then since this is an adjunctive code, you have the ability to now plasti or stent. So in this particular case, we used an ELUVIA DES. We basically did the stenting. And then after the stenting was done, this is our completion angiogram, which now shows very good, more streamlined flow coming down the SFA popliteal area, which is what this patient would need to heal. And then, of course, we have to touch up the anterior tibial and the tibioperoneal trunk, get in line to vessel runoff to the foot, which then goes on to heal the foot. So thank you again for your attention, and thank you, Boston Scientific, for inviting me to SIR. It's my first time here. I'm like a kid in a candy store. I'm so excited, but thank you.
Thank you, Sonia, and we would love to have you back. So, but one question. So, many people will say, why bother using IVL if you're going to put in a stent anyway? How does using IVL, impact your stent, drug-eluting stent decision?
Yeah, great question. That's actually why I got into atherectomy, because what I found is if I just did a straight balloon angioplasty and then a stent, I wasn't getting the expansion and the luminal gain that you need without really hurting the artery. In other words, you really balloon the crap out of the artery, and then you put the stent as the as the scaffold in, and then you come back 6 months, 8 months, a year later, and the patient's got a lot of intimal hyperplastic reaction. So there's a role for the drug elution, but it really, at the cost of expanding and blowing up this artery, I think this is a much gentle way, which is why I like the atherectomy rotablator only comes in smaller sizes, but I use it in the SFA POP for a lot, close to 500, 600 cases. So I think this is going to be a really nice therapy because it's a diffuse disease, same balloon, cost effective, time effective, to be able to do your plaque modification. Now you go in with your ELUVIA or Ranger if you choose to, or just a stent, and you'll get the stent expansion and the luminal gain you want.
Perfect, especially with that big chunky calcium that you showed in the more proximal aspect of that lesion. Great. Thank you so much, Sonia. And we're going to get into the OBL discussion a little bit too. All right, Rahul.
So I'm going to show two cases for SEISMIQ with some drug elution here. These are my disclosures. So the first case is an 88-year-old gentleman with a history of coronary artery disease, the usual sort of mishmash of post-medical history, AFib, Allen Eliquis, and basically comes in with a non-healing ulcer in his left foot. It's a deep wound on the lateral aspect, basically wants and needs revascularization. And he also has ischemic rest pain. So this is his ulcer. And so we brought him in for revascularization. So here's his angio. I'm not sure. So this one doesn't play, but yeah. So you can see sort of his angio, sort of this dense calcifications, probably some CTO. He's not completely asleep. This is sort of our patients. They're kind of moving around a little bit, and you can see the angio there. So it's a lot of calcification, a lot of stuff to cross and work through. So again, we were able to cross this, and we used the SEISMIQ balloon. And again, I think Sonia and Parag kind of hit on this a little bit. I think in the past, our mainstay would have been to okay, we're going to cross, we're going to pre-dilate, we're going to put in a stent, and we're just going to take the highest pressure balloon and see if we can just blow this artery out, right? And try to get as much luminal gain. I think with this technology, we don't have to do that anymore. I think we can just sort of crack the calcium and see if we can make the vessel more compliant. The goal isn't necessarily to get rid of the calcium, right? So I think when we do these cases with my fellows, they're like, well, it doesn't look any different. I'm like, it's not really supposed to look different, right? It's supposed to make the vessel more compliant so that when you go and put in your final therapy, whether that be a DCB or a drug-eluting stent, you get that good luminal gain without actually having to sit there and try to really crack or blow out the calcification. So, that's the angio post. Yes, there is better flow through, but in reality, my fellow was like, it doesn't look all that different. And I'm like, it'll work. Don't worry. We're gonna keep going. So again, we were able to use a singular balloon, do multiple pulses through. The directionality also is super helpful. You don't necessarily, those emitters are really easy to see. So it's really easy to reposition. So you don't necessarily need to reposition a whole 6 centimeters of distance. Sometimes just moving the balloon about a centimeter or two just to get those emitters to go from anterior posterior to left to right, just so you can get sort of that, really hit that concentric calcification. Again, and then you can also and you can also turn off the emitters. So in those areas where you had sort of denser calcification, you can sort of really focus on those areas. It doesn't necessarily mean you're getting more energy because you've turned off those other emitters. It just means you've saved some of those pulses on those other emitters to use later. So you can sort of focus and get more use out of the balloon across your treating segment there. So again, this is the IVUS. It's going to run a little slow. So this is the angio after all of the IVL. And this is the IVUS. And again, we've gotten good luminal gain with just this balloon. We're not taking this up to 10 atmospheres, we're not taking it up to 12 atmospheres. It's really like 4 to 6. That's sort of the range. The feedback is really good. You can really see sort of the compliance of the vessel change in real time. As opposed to looking at the insufflator and seeing if that needle's like moving down, you get sort of a real-time feedback on the monitor to see the pressures come down, and you can wind it back up if you want to, or you can just let the pressures come down. And again, so that's, this is not going to be our final therapy. I don't think IVL is to be designed to be the definitive therapy. It's just to make whatever your definitive therapy is going to be safer and easier to get to. And so ultimately we ended up placing ELUVIA stents here, drug-eluting stents. There's still that area of sort of dense calcification, but when we did it, it wasn't flow limiting, even though it looks kind of funny. We don't really see any collaterals, and the flow's really good. We got a palpable pulse at the end, and the wound is starting to heal. This next patient, not all my patients are cancer patients, but these both happen to be cancer patients. So it's a 62-year-old gentleman with stage 4 thyroid cancer. He has hemoptysis secondary to mucositis and PVD, presenting with a small right heel ulcer and foot pain. They tried conservative management, but the ulcer is not fully healing, and it's really affecting his life. So this is the CT scan, and again, you can see probably really short segment CTO, but a lot of diffuse dense calcification throughout the SFA there. And this is the angio here. So these are still images. You can see, again, there's decent flow. Here's the short segment CTO. Again, not super hard to cross, but the problem is going to be really how do you treat this and fix this. And again, given his mucositis, he does have this hemoptysis. We don't really want to escalate his anticoagulation because I don't know if he's going to be able to fully tolerate. So we want to try to get out of this without having to stent him, to have to sort of commit him to aspirin and Plavix post-procedure, or the risk of stent thrombosis. So again, we used SEISMIQ here. We were able to basically crack this calcium, multiple segments. Even though it's a very long segment SFA, a singular balloon was able to cover all of this, and we were able to sort of crack all this calcium. And again, so to again reiterate, you basically get a lot of feedback from the console itself, and I think that's right now. I think that's really a really big selling point for this, is that console does really give you a lot of information and gives you a lot of control over the balloon and how you use it. Therapy is at 4 atmospheres, but that's really all you need, and that's sort of the point. And it gives you everything, that balloon inflation time, everything's right there, so you don't need to set a timer, you don't need to keep monitoring the pressures. It's all right there on the console for you. So this is the post-SEISMIQ IVL, or post-IVL angio, and you can see it looks good. Could you make the argument you could just get away with just doing plain old balloon angioplasty? Maybe, but we decided that we were probably just going to DCB this. So we just used long segment Ranger. So we basically used 2 Ranger balloons to sort of cover the segments to 6 millimeters. And so there's the post-angio. So palpable DP and PT pulse at the end of the procedure. And then again, 1 month follow-up shows wound healing. Thank you.
Great. Great case. So you talked about the inflation pressure being low. Are you seeing far fewer dissections that you have to stent now in your practice because of that?
Yeah. So it's not going to be 100%, but the amount of dissections we see from the pre-angioplasty, so with the IVL, we don't really see it because we're not really going to a pressure that would sort of tear the vessel.
Great. All right. And then we'll have Nick round us out, and then we'll have a panel discussion. Thank you.
All right, thanks, Keith. Thanks, Boston, for having me here. So we're going to switch gears just a little bit. I wanted to talk a little bit about my favorite atherectomy device, which is Jetstream. And so I don't know, for those of you who haven't ever used Jetstream or have Jetstream in your practice, I would encourage you to get your hands on it and at least have a little trial of it, because I think that this device has some very unique properties that we don't really get with other atherectomy devices. And we'll go through this by the way of a case here. So this is a recent case of mine, 48-year-old male, end-stage renal disease. He's on hemodialysis. He's active, still smoking, over 40-pack year tobacco use, which is impressive given that he's 48 years old. CAD, hypertension, hyperlipidemia. He's obese. He has 3 months right lower extremity severe rest pain, non-palpable distal pulses. He's got monophasic DPPT. His ABI was 0.7 on the right, non-compressible on the left. I'm thinking it's probably overestimated given the degree of calcification he has, and just based on his exam, I'm thinking he's got some combination of fempop occlusion plus tibia perineal disease. So this is what his angiogram looks like, and so this is his distal SFA into his P1 pop, and you can see across the knee he's basically got a P2 through P3 pop occlusion, and brings it right back on that third image. You could see the AT coming back. There's not much of a nubbin like retrograde. It pretty much the lesion, the distal cap, pretty much just abuts the trifurcation right there. So I thought this was a tricky lesion in a relatively young individual. Granted, he has a lot of comorbidities, but I'm thinking, can I get away without putting a stent, here? The guy's got all this other reasons why he may be a little bit non-compliant and why we may have elevated risk of stent thrombosis. So certainly that's our backup option. So here's what we did. We take my typical strategy, which is I cross everything with this to start with, which is an 018 Rubicon and 014 glide wire Advantage. I crossed beyond it. It felt like a luminal cross for the most part. I entered the TP trunk and down the PT, so I feed my wire down the PT, and I'm thinking, well, okay, maybe I'll just take this right down the TP trunk into the PT. I do a selective PT injection, and it turns out he got pretty bad plantar arch disease on top of this. So I got a little worried that if I this is what his PT injection looks like, and you can see like it's just kind of stopping at the arch. So I started to get a little bit worried if I was to, let's say I put a scaffold and I direct things down the TP trunk into the PT, or vice versa, I go into the AT and I direct it down there. I thought the outflow of both wasn't going to be great, so I was hoping to try and preserve the whole bifurcation without any scaffold. So I brought a catheter down and I buddy wired out the AT origin just to make sure I could preserve that true trifurcation of the origin, and I was thankfully able to do that. He had a little prox AT stenosis that we dilated, and I sort of pre-dilled things. It basically ballooned the AT into the P3 and then ballooned the TP trunk into the P3. And then this is what his the IVUS looked like at that point. So that was really just a pre-dilation. And the IVUS will show you sort of the characteristic of this lesion, and you can see he's got extensive medial calcinosis, but this lesion is heavily fibrotic as well. So there's fibrofatty plaque, there's fibrotic plaque, maybe there's a little bit of thrombus, but then if you look in that mid-segment, there's also a decent calcific rock there. And that's the cool thing about the Jetstream, is that this is an atherectomy device that treats fibrotic plaque, fibrofatty plaque, treats thrombus, it has aspiration, and does very well against calcium as well. So I thought this was a great case for Jetstream. And when I think of atherectomy devices, I kind of think of them as, you have those for calcium and you have those that are not. And then you have those that sort of change compliance and those that give you better luminal gain. And Jetstream's kind of one of those that is a jack of all trades for the types of plaque, but it's more of a luminal gain type device. So I thought it would be good here if I was trying not to leave a scaffold behind. And so that's what I did. I took the 2-1 Jetstream down through this lesion, twice actually down through it, once down the AT, once down the TP trunk to make sure I got a common lumen. And then I used an adjunctive scoring balloon as well. And then I re-IVUSed, and I thought it was going to look pretty good. I followed everything with a 5 millimeter Ranger DCB, and we had a very nice result, I think, for leaving nothing behind there. I was very happy with that. Now you can see better, just that degree of plantar arch disease. So I'm kind of glad we didn't have to put any metal in there. This is what that IVUS looks like post, and I think what you'll see is that we've gotten good, luminal gain. we've effaced, you'll see that calcium rock in the middle, and you'll see that that's pretty well effaced and debulked. I don't think there's really any significant dissections here, and certainly the float, that was that calcium area right there. But you can see it's done a pretty good job, and I actually didn't use any distal embolic protection for this. It does have aspiration on it. I think if you go low and slow with this, you can get by without any embolus. We started him on dual antiplatelet, and he did have complete resolution of his rest pain. I'll just give you very quick notes on Jetstream in case you're not familiar. So there's the Jet Registry. Looked at this. It was basically a 12-month outcomes looking at real-world registry data, long fempop lesions. Third were CTOs, kind of like I just showed you, with really good 77% patency, 81% freedom from TLR 12 months. There was no drug in this study, so that was just Jetstream plus POBA. There's a Corvus study more recently was released, and this was a observational study, retrospective, 8 centers, 588 patients, and we basically did propensity score matching between those randomized to a drug-eluting stent or DCB plus Jetstream, similar to the case I showed you. And you could see that the freedom from TLRs were comparable between the two. So one with a primary DES strategy versus the other being an atherectomy DCB, leave nothing behind strategy, and they did perform fairly similar. One quick note, because we touched on it, and I also, and do about 80% of my cases in the OBL, and so with SEISMIQ, it's exciting with this new IVL technology, but also equally exciting is in 2026 we can actually bring IVL, outside the hospital now, and we can use it in the OBL. And just looking at the reimbursement numbers, because I get this question a lot, does it make sense? Can you use IVL in the OBL? And the answer is yes, you can now. If you look at the numbers, it pretty much offsets the cost of the catheter when you're doing a single level. And in some patients that might require multi-level disease, you can actually, there's even a little bit margin beyond that. So it does become financially feasible to do this now outside the hospital, whereas previously it was not. Thank you.
Great. Really excellent cases, so thank you for that. And if you have any questions, we'll take them here. I guess you ended on the whole OBL thing. We have Sonia here, and I know everybody's got a very diverse practice, but kind of tell me about kind of how your practice in the OBL has evolved with not just IVL, but drug elution and employing use of, Ranger ELUVIA into your practice. Sonia, we have mics up here, so I'd love to hear from you.
It's a great question because, OBL, ASC, hospital, they're just sites of service, and I think all of us want to do the best quality care we can. And unfortunately, we are limited by the economics of the situation. So in our lab, it's like stealing from Peter to feed Paul. So if we have a great day, a lot of cases, and somebody needs a drug elution, which is not reimbursed in the OBL, literally we'll have one patient who will do because we know we'll have enough, we've done well enough in that day that we can, offer a drug elution strategy to that patient. So we have it on our it's available to us, but I have to be honest, it's not like I use it for every single patient. I use it for the one who's failed disease or is coming back or is critical limb threading. Like I pick and choose. This is what I meant by Peter and Paul, is I pick and choose where I can use my drug elution. I can't use it for everyone. So that has not changed, but because the reimbursement for the OBL has now changed this year, and IVL certainly allows me to use it, I feel like I'm now going to be able to offer a little better therapy that the patient could get at the hospital that I couldn't schedule at the hospital for whatever reason, which is a whole other discussion about how you can get access to the hospital to do these cases with a revolving door of staff, etc. So I think it's going to make our lives a little bit easier to offer great quality care at any site.
Great. Anybody? How do you make your decision between, Nick, you showed us a great atherectomy case with Jetstream, but how do you make your decision between atherectomy or IVL, Parag? Anybody, Rahul? Or both? The Dr. Patels, one then the other.
Sorry, one of the Dr. Patels. So look, I think Part of it is the level of calcium. So I think Jetstream does well for sort of that intraluminal calcification, where Jetstream doesn't do so well, and it's not just Jetstream, and any of the atherectomy devices aren't going to do well, is for that medial calcinosis, where the vessel is just calcified. So your classic sort of diabetic arteries, and they're also more prone to dissection and having to stent, and then when you start to dissect and stent, you end up having to extend longer than you probably would like to. So I think that's an easy pivot point. So that's sort of how I decide between the two.
Yeah, great.
So, for us, we've never been a big or high volume atherectomy site, but we've always carried it and we've used it in niche areas where I didn't want to stent, frankly, is what it was. And so this has largely started to replace some of that area. I do think there's a role for it, but it's typically in areas where I want to try to get a better balloon angioplasty result and try not to leave something behind. And so we've tended to use IVL in that setting, and I think it's taken the share of what would have been a primary atherectomy approach to accomplish that, to get that improved vessel compliance.
Great. Yeah.
It's funny because you mentioned something, and that's exactly kind of how my practice has evolved. The more and more I use IVL, I used to see IVL more as this is going to soften things up, change compliance, and get my stent better expansion. Now, more and more, slowly over time, you start to gravitate. You realize, wait, I don't need the stent. I can get, if I just take my time with this and I get proper treatment, I don't have to leave something there. So I would say, year over year, the more I've used IVL, the less likely, the more I see it as a technology for leave nothing behind, which was not my initial impression with it.
Okay. Talk to me about your use of IVL and potential, advantages with SEISMIQ outside of FemPop, or do you use it in iliacs? When does it come up? How do you address other cases? Anybody?
So we have used it in iliacs. I haven't used SEISMIQ specifically, but IVL in general for when we do EVARs to use it to crack the iliacs if it looks sort of calcified, sort of on the smaller side, just to get the sheath to make it a little bit safer. I know people have used it in the common femoral. We've definitely used it in the common femoral in places where you can't do an endarterectomy to maybe get a little bit more compliance, because you definitely don't want to stent there. So maybe just to crack the calcium that's there and maybe make the therapy a little bit safer.
Yeah, same. We haven't, for us, another common area that we see, and I've used, in this case, Shockwave, was in visceral vessels that are calcified. And knowing that I'm going to have to stent that segment, this is typically the definitive therapy, but you're worried about luminal gain. High pressure balloon angioplasty with a covered stent isn't very comforting, particularly if you end up with a dissection in that location, is really problematic. So to get an IVL treatment that helps you with a better lower profile stent perhaps, and not requiring certainly a high pressure inflation to get good luminal gain in those settings becomes really enticing. And so that same concept holds true with common iliacs and aortic reconstruction if you have densely calcified. And then assisting us to get large bore devices up is the other place that largely is done in the cath lab, but for our EVARs and aortic cases, we will certainly use that to help us, as opposed to the previous model, which was, either get the sheath up and then be prepared for an iliac on a stick, or put a Vibon up, intentionally rupture just to get your luminal gain to get a device up. We've kind of moved away from those latter two scenarios, which is not an ideal situation to be in. So this has helped in that as well.
Great. So let me, somebody brought it up, the common femoral artery. I'm glad we have a vascular surgeon here, because, we have data coming out actually in a couple weeks about common femoral drug elution. But we had always thought that was a no-touch zone, right? Our vascular surgeons would, not like that. So talk about common femoral treatment. And
so, common femoral is in a kind of a unique position in the body, right? So it's a common femoral, which is at a flexion point. There's an important profunda coming out. There's the origin of the SFA. And then it's across the joint, so you don't want to stent it. It is also the place we access a lot to do procedures. So I think common femoral, vascular surgeons defending our territory and say, oh, you can't touch the common femoral. God knows I have instrumented many common femorals, because you kind of have to. So I think from a surgical standpoint, it's a great place to offer a patient, provided they can manage and handle general anesthetic, surgery, a month of follow-up where they're going to have a swollen leg, pain, possible infection. Like, that's the reality of common femoral surgery, not just, I feel great doing it because I am a vascular surgeon, and but what about the patient, right? So when you actually look at it in totality, it's not free. There's a lot going on in that common femoral. It's a very durable procedure. If you can get them in and out of it without a lot of complications, it's a great place for next endovascular therapy, right? So there's a lot of ways you can work with your vascular surgeon or general surgeon or cardiac surgeon who does common femoral angioplasty for you with a hand-sewn anastomosis, protects the profunda origin, protects the SFA origin. Like, there's a lot of hybrid stuff that can be done with the common femoral. So I think that's kind of where how the common femoral should be looked at now. The fact is, a lot of our patients cannot handle surgery. So what are you going to do? Not offer them a procedure? Of course not. You're going to do what you can to use IVL, do atherectomy, potentially covered stented because it's got a pseudoaneurysm, because it got ripped. Like, you have to do what you have to do on that day, at that time. So just defending it because it's a vascular surgery territory, I think, is nonsense.
You're definitely invited back to the FCR next year. I mean, we see increasing number of cases with IVL in the common femoral and drug elution. It's actually I don't want to say exploding, but it's like a lot more common, and the results are very durable. So, comments, anyone?
Well, I was just going to say, I mean, having this kind of a
Mike?
technology to treat at a place we didn't want to leave a stent in. So that was the whole point, right? We didn't want a stent across the common femoral. Flexion point, jailing off the profunda, reaccess, all those points aside, now you have something that can probably possibly modify the lesion, put some drug in, get some luminal gain, and has none of those issues with an implant. Very compelling, right?
Yeah, great. All right. Any questions from the audience? All right, perfect. Well, thank you on behalf of Boston Scientific. Thanks for coming to this lunch symposium. I know they have information about SEISMIQ over at the booth and drug elution and everything else you want to hear about. So thanks again and enjoy the meeting.